Hello everyone, welcome back to microlearning program of MFM. Today I would like to discuss about anaphylaxis. The topic is insights in anaphylaxis. What is anaphylaxis? It is severe, generalized, or systemic hypersensitivity reaction characterized by rapidly developing life-threatening airway, breathing, and circulation problems usually associated with skin and mucosal changes. There are many allergens in the world and some may be unidentified yet. Here are some common allergens. Food allergens are like hen's egg, cow milk, wheat, shellfish, peanuts, and so on. There are so many food allergens. In venom, bee sting, wasps, for drugs, antibiotics, NSAIDs, anesthetic drugs, and also radio contrast medias are allergic to some people. This slide shows two line graphs about hospital admissions due to anaphylaxis and fatalities due to anaphylaxis. Data are from research done in the UK 1992 to 2012. And trigger factors are food, allergenic, and insert stings. On the left side, it's the line graph about hospital admissions due to anaphylaxis. This blue line represents anaphylaxis by food. It is the highest in young age and it is the lowest in the elderly age. For allergenic, it is the highest in the age above the middle age and it is the lowest in young age. On the right side of the slide, it is the line graph about fatalities due to anaphylaxis. Food anaphylaxis is the highest in the teenage years and is the lowest in the elderly ages. For allergenic anaphylaxis, it is the highest in the elderly ages and is the lowest in the young age. This orange line represents anaphylaxis due to insert. To compare insert anaphylaxis to food and allergenic factors, it is less likely for both hospital admissions and fatalities. World Allergy Organization said the most severe patterns of allergic reactions meet one of the criteria of the following. Anaphylaxis is highly likely in case of typical skin symptoms and significant symptoms from at least one other organ system. Or the second criteria is exposure to a known or probable allergen for that patient with respiratory and or cardiovascular compromise. This slide also shows criteria for anaphylaxis. Anaphylaxis is highly likely when any one of the following two criteria. The first criteria is that patient will present with acute onset of an illness which occurs within minutes to several hours with simultaneous involvement of skin, mucosal tissue, or both. Like symptoms and sinus symptoms may be generalized hives, pruritus or flushing, and swollen lips, swollen tongue, and swollen uvula. 1 plus and at least one of the following symptoms is the first criteria. A patient may present skin symptoms together with respiratory compromise or severe symptoms like reduced blood pressure and severe GI symptoms. If patients present with respiratory compromise, sinus symptoms, will be dyspnea with bronchospasms, stridor, reduced PF, and hypersemia. If CVRs present together, there will be hypotonia, collapse, syncope, and incontinence. If GI symptoms are involved, there can be severe crampy abdominal pain and repetitive vomiting. Here to know that here is especially after exposure to non-food allergens. Non-food allergens but patients present with severe GI symptoms. 1 plus A or 1 plus B or 1 plus C is the first criteria. The second criteria is that the patient will present with acute onset of hypertension, that is CVS compromise, and bronchospasm, respiratory system compromise, and laryngeal involvement after exposure to a known or highly probable allergen. And the symptoms will occur from minutes to several hours, even in the absence of typical skin involvement. If the patient meets one of these two criteria, anaphylaxis is highly likely for that patient. In anaphylaxis, skin involvement is about 80 to 90%, and this show skin symptoms are very common in anaphylaxis. However, there can be some cases which are severe anaphylaxis, but there may be no involvement of skin symptoms. For respiratory system, it is about 70%. For CVS, it is 45%. For CNS system, it is only 15%, and it is the least involved system in anaphylaxis. Time course for fatal anaphylaxis. Where anaphylaxis is fatal, death usually occur very soon after exposure to trigger. Fatal food reactions typically cause respiratory arrest after approximately 30 minutes. For insustained anaphylaxis, it can cause collapse from shock after 10 to 15 minutes, and death caused by IV mitigation can occur most commonly within 5 minutes. It is the first one. Cardiorespiratory arrest more than 4 hours after exposure to initial allergen is rare. This is spectrum for severity of allergy symptoms. If the patient presents with only mild or localized skin symptoms in or swelling of lips or face, or maybe the patient present with even generalized skin reactions, but there is no involvement of airway, breathing, circulation, it is not anaphylaxis. But if the patient presents with airway or breathing or circulation problems, it is considered as anaphylaxis with or without skin symptoms involvement. For investigation, we can check mast cell tryptase. You have to do 3 times hard sampling, and it's not raised in food allergy, and it cannot exclude diagnosis. However, we don't routinely need investigation because we can get diagnosis from signs and symptoms of the patients and give appropriate and in time treatment and care. The main treatment for anaphylaxis is intramuscular adrenaline or epinephrine injection at the anterolateral mid-thigh, 5 to 15 minutes at interval. This slide shows dose of adrenaline used in anaphylaxis. This slide shows respiratory rate of intramuscular adrenaline injections. Respiratory rate to one dose of adrenaline is about 87.8. Respiratory rate to 2 doses is about 10, and some patients with severe anaphylaxis may need more than 2 doses of adrenaline, and its rate is 2.2. By looking at this slide, the percentage of respiratory rate to 1 dose of intramuscular adrenaline injection is really high and a good one. So if we can diagnose patient with anaphylaxis in time and can give proper treatment and care, we can reduce fatality of a patient by anaphylaxis. However, there can be some time that patient may have no improvement in respiratory or cardiovascular symptoms even after 2 appropriate doses of intramuscular adrenaline. That kind of anaphylaxis can be considered as refractory anaphylaxis. At that time, we have to prepare to give IV infusions, so we need to prepare for IV line, and we may also need to seek expert help as early as possible. In that kind of case, we may need to give intravenous or intraosseous fluids or adrenaline infusions, and here is the DJ treatment for refractory anaphylaxis. It is according to UK guidelines 2021. It is true that the main treatment for a patient with anaphylaxis is intramuscular adrenaline or epinephrine injection. However, patients may need other support in care because patient may have respiratory and cardiovascular symptoms. So if cardiac arrest present, CPR must be done. If patients have cardiovascular signs and symptoms, we have to prepare to give IV fluids, and we prefer to give non-glucose containing crystallized isomethylamines or plasmolite rather than 0.9% sodium chloride to be able to reduce the risk of causing hypochloremia. And the amount of fluids to be given for adults is 500 to 1000 ml, and for children it is about 10 ml per kg. It can be considered to give glucagon when symptoms remain refractory to adrenaline and aggregate fluid resuscitation. If respiratory distress present, we must give oxygen, and we can give a salbutamol inhaler to relieve bronchospasm. In anaphylaxis, positions of the patient is also important because the patient may have cardiovascular symptoms like hypertension, so we need to make patients lie flat with or without raising legs, but it is more preferable to raise legs, and patients should not be allowed to stand up. If patients also have respiratory symptoms in addition to hypertension, which is cardiovascular signs, it is better to make the patient in semi-recumbent position. For pregnant patients, it is better to make them lie on their left side to prevent orthocaval compression. If necessary, with the bed in head-down position. Antihistamine can also be given in anaphylaxis only after initial resuscitation. Here, we have to notice that this one non-sedating or antihistamines like for example cetirizine should be preferably given because intravenous antihistamine may cause hypotension. So the European Academy of Allergy and Clinical Immunology recommends to give oral administrations of antihistamine. Antihistamine is given to release the skin symptoms of patient. For corticosteroid, it's not given routinely, but it can be considered after initial resuscitations for refractory reactions or ongoing asthma or shock. But we can give corticosteroid as a substitute of adrenaline because adrenaline is the main treatment of anaphylaxis. In asthma, early corticosteroid treatment may be indicated where an acute asthma exacerbation can contribute to a severity of anaphylaxis. And if it is possible, it is better to give corticosteroid orally. Primary options is hydrocortisone sodium succinate for children, 4 mg per kg IV as an initial dose, maximum 200 mg per dose. Adult 200 mg intravenously as initial dose. However, it is better if we can give corticosteroid orally. Monitoring after acute treatment is also important because there can be biphasic reactions. Biphasic reactions occur in up to 20% of patients, usually within 10 hours after resolutions or symptoms. Risk factor for biphasic anaphylaxis are the patient might have experienced severe anaphylaxis and needs more than 1 dose of epinephrine, high blood pressure, and there was an anaphylaxis trigger, cutaneous sinus symptoms, and if the case was a medication triggered anaphylaxis case in children, these are risk factors for biphasic anaphylaxis. There are also other predictors for biphasic response. By looking at severity at presentation, hypotension, laryngeal edema, chronic beta blocker use, and delay or antigrade dose of epinephrine, we can predict the possibility of biphasic anaphylaxis. According to Resuscitation Council UK, it recommends observation for at least 2 hours after resolution of symptoms for patients with a good response to a single dose of adrenaline given within 30 minutes of onset of reaction. A good response was within 5 to 10 minutes, and the patient had complete resolutions of symptoms and has unused adrenaline auto-injectors and has also been trained how to use them. And there can be also adequate supervision after discharge for the kind of patient after observations for at least 2 hours after resolution of symptoms, we can discharge him. For patients who needed to get 2 doses of intramuscular adrenaline, the patient may need to be observed for at least 6 hours after resolution of symptoms. If the patient had severe reactions requiring more than 2 doses of adrenaline, and also there are some symptoms like severe asthma or reactions involved severe respiratory compromise, and there was possibilities of continuing absorption of the allergen like slow release medicines, and the patient might present late at night, and if the patient had possible inability to respond to deteriorations like CNS symptoms involvement, and if there is difficulties in assessing emergency care, the patient should be under observations for at least 12 hours following resolution of symptoms. For distress care, all patients who have experienced anaphylaxis should be sent home with the following. They should have an anaphylaxis emergency action plan, and if the patient seems to have good compliance and reliable, we can give health educations about anaphylaxis and preventions, and we can make them have at least one epinephrine auto-injector in hand, or he may need 2 auto-injectors with instructions to fill the prescriptions immediately. And the patient also should have printed information about anaphylaxis and its treatment, and also documented advice to follow up to an allergist, and sometimes he may need a referral if possible. These are medical alert bracelet used in some countries for patients who usually get anaphylaxis in are allergic to some specific allergens. They use like this. These are really beautiful in looking and also useful for health purpose. By looking at these bracelets, and if someone from the surrounding see him or her with some kinds of symptoms suspicious of anaphylaxis, they can help the patient to get proper treatment and care, maybe by first aid or send them to the nearest hospitals or somewhere to be able to get medical help in time. Mortality of anaphylaxis. Overall prognosis of anaphylaxis is good if the patient can have appropriate treatment and care in time. So, case fatality rates of under 1% in those presenting to hospitals in the UK, and the rate within general populations of less than 1 million per year. For food anaphylaxis, case fatality has been halved between 1998 and 2018. Increased risks of death, pre-existing asthma, particularly if this is poorly controlled, or if treatment with adrenaline is delayed. Um, in hospital, the mortality rate of anaphylaxis is less than 1%. In community, it is less than 1 per million per year. This is conclusions for today's topic. Fatal anaphylaxis occurs within minutes. Food allergy after 30 minutes. For venom, it's after 10 to 15 minutes. For drug allergy, it can cause within 5 minutes. And the main treatment is intramuscular adrenaline injection, 0.5 milligram for adult at the mild lateral thigh, 5 to 15 minutes at interval. In 10% so our patient may need 2 times of adrenaline injections. The case that need more than 2 times of intramuscular adrenaline are considered as refractory anaphylaxis, and that kind of case may need to get IV infusions of adrenaline. Other notable points are we can also give antihistamine, preferably to give in oral administration to relieve skin symptoms. Corticosteroid is considered for refractory reactions, shock, and asthma, but we need to be aware of that. Corticosteroid is not a substitute for adrenaline injection, although it can be given in anaphylaxis. If there was hypotension, we can give crystalloid effusions, and we can give nebulized salbutamol for relieving bronchospasm. These are references. Thank you so much for your attention. Have a nice day. See you later.